Thank you, Dr. Mehran. It's always hard to follow after Vinny. Okay, so neuroprotection in TAVR, these are my disclosures. Um, let's look at the incidence of stroke after TAVR. So if you look at the trial data, 30-day reported stroke is around 4%, give or take, around 9% in the Sentinel study. And if you look at the older devices, older trials, around weighted average of 4.2% and a weighted average of 3.1% in the newer studies. Now compare that to your registry data or the TBT data. So it's less than 2.5, more or less 2.2 to 2.3 is your stroke, and ischemic stroke is even lower. So TIAs run around less than 0.5. So there's a little discrepancy between your trial and registry data, but that is expected because trials mandate more neurosurveillance, which registry does not. All right. Most of the neuro events, as Dr. Samir Kapadia has shown us, happen in the first 48 to 72 hours. So this is the data from the partner high and extreme risk, 2,621 patients, and most of the neurological events happen in the first 48 hours. And otherwise, it's a very low constant risk of 0.8% per year. So stroke is not benign. It has its own sort of morbidity and mortality associated with it. And what are the predictors of early and late stroke? So this is a little bit interesting because early stroke, which happens early after TAVR, can be divided into patient factors and anatomic factors. The patient factors are mostly prior stroke or TIA, a new onset atrial fibrillation, a CHA2DS2-VASc score which is more than 5, and a peripheral vascular disease or patients who are older. Anatomic factors are longer procedure time, rapid pacing, valve repositioning, post-dilation in certain studies, small aortic valve area, and if you have a large burden of aortic atheroma. Now, late stroke more than 10 days, I think is more of a patient protoplasm, a small BSA, severe aortic calcium, chronic AFib, and leaflet thickening. So these are predictors of early and late stroke. So neuroprotection. Why? First of all, let's see how neuroprotection works. In my opinion, there are three ways. It's mechanical, pharmacological, and procedural. Most of us link neuroprotection to use of embolic protection devices, but I think it's actually a three-pronged strategy where you have mechanical, pharmacological, and procedural. And why is it important? I think, first of all, we have to understand that there is clinically stroke and TIA that manifests in these patients, and that is associated with a poor quality of life, morbidity, and mortality. Now, there is also some data to support that there is brain injury on MRI, which is seen in 70. If you do an MRI on all the TAVI patients, 70 to 90% of them will have some sort of lesion. And then this neuronal injury without symptoms or subclinical CVA has long-term neurocognitive sequelae. So yes, it is important. Now, question is, let's look at the mechanical or cerebral embolic protection. What is an ideal device? An ideal device protects the ostia of all three vessels, is safe, low profile, deliverable, and retrievable, remains stable during the procedure, does not interfere with your procedure per se, and preserves the integrity of the calcified aortic arch. So the two types are either there's a filter, which is the currently commercially available Sentinel embolic protection device, or you have a deflection catheter, which is inserted from the groin, a 9-French sheath, and basically deflects the debris of the three great vessels. So that is not something we're using here. It's not commercially approved. So we'll focus on the Sentinel embolic protection device. So this is how it's done. As you can see, the three big vessels. You deploy your filter in the, let me go back here. I don't know if I can. All right. Okay. So you deploy a filter in the brachiocephalic, and then you also cover the left common carotid. The only issue with the Sentinel is that the left vertebral, which comes off the left subclavian, remains uncovered. So there is partial coverage of the tree. Now, this was the Sentinel device. Patients were randomized in a 1-1-1 fashion, 363 patients, and they were randomized to a safety arm, which was TAVR with Sentinel, a test arm, TAVR with Sentinel, and a control arm that was TAVR only. And the main primary efficacy outcome was the new lesion volume on MRI. The other thing they wanted to look at was the primary safety outcome, which is the 30-day MACE rates. So the device met the primary safety outcome, but there were no differences. Although there were numerical differences between the control and the device arm, the new lesion volume was actually lower if you use the Sentinel device, but it did not meet statistical significance, primarily because of the smaller sample size. But what did the trial tell us? I think this was a very informative trial. It told us that the device is very safe to use. The 99% of patients, the Sentinel actually captured debris. So any patient you're doing a case on or a TAVR on, you don't want to see that debris going in the brain. So I think that was a very sort of reassuring thing that, yes, we do capture debris in 99% of patients. And the total procedure time only increased by 13 minutes. So this is what I was talking about, that the left vertebral remains uncovered. So you have around 2% brain volume, which is unprotected, and you have 24%, which is partially protected. So I think Sentinel at this point is better than nothing, but that's my opinion, and I'll tell you why. This is a very interesting patient-level propensity match study, which used the Sentinel IDE, the Clean TAVR trial, and the Sentinel all-comers study. So what it showed was that the all-cause stroke was actually lower if you use cerebral embolic protection. And this was primarily driven by lower numbers of disabling stroke. Now, a lot of meta-analyses were done, and this is one from our group, which shows that actually there's not much difference if you look at the pooled effect estimates. But these studies included all types of devices. You can see it's the Deflect, you have the Clean TAVR, so different devices were used here. So where are we now? So the issue with cerebral embolic protection is that you have data from the Sentinel IDE study, you have data from multiple meta-analyses, and you have data from the administrative data sets that tell us, well, you know what, maybe you're decreasing the volume on MRI, maybe you're decreasing the number of lesions, but does it really impact a clinical outcome? So this was the nationwide readmissions database. Again, no difference in outcome. This was the TVT data that basically showed when you did the instrument variable analysis, it was non-significant, but when you did a propensity match analysis, it was significant. So where are we now? I think what we're dealing with is an equipoise. It's a clinical equipoise where you don't have enough randomized data to tell us whether Sentinel is to be used or not, but we know Sentinel is safe, and if at all, if we can try, we should use it in our patients. Now, to put at rest this clinical conundrum of clinical efficacy, we are now in the, Dr. Kapadia is running the Protected TAVR trial, which is going to randomize 3,000 patients, 1,500 in each arm, and this one, the primary endpoint will be stroke at 72 hours or discharge. This will be the only trial that actually looks at stroke per se as a primary endpoint. Now, what is the neuroprotection strategy that we do apart from using Sentinel is we have mechanical, pharmacological, and procedural. Like I said, you have partial reversal of anticoagulation for those with AFib and a high CHA2DS2-VASc. No reversal for patients with a sludge or smoke in the left atrial appendage. Patients who are high CHA2DS2-VASc are extreme risk, in my opinion, for a stroke. Now, the question is, should you be doing more pre-procedural anticoagulation and minimize your procedure time and minimize your interruption in these cases? And just one point about our stroke protocol. The only key here is post-TAVR patients are very high risk for bleeding, so we really limit the use of TPA if at all they have a stroke. And unless they have a large vessel occlusion, they go to neurosurgery. Thank you so much.